Hello, everyone, and thank you for joining this webinar. I'm looking forward to covering Mpox vaccination and what we know about it. Here are my disclosures. What we can see in this slide from the World Health Organization in terms of global Mpox surveillance, cases by month and by region, is that in all regions, the number of cases is going down since the 2022 outbreak, other than in Africa at the top, where you can see that the absolute opposite is happening and cases are rising exponentially, and this is of great concern. But I'm going to talk a little bit about how we got to the point where the clade 2B outbreak was actually contained. So I guess some of the key factors that were involved in containing this outbreak were firstly working with communities and delivering on behavioral change. That was very important. But also vaccination played a role. And I'm going to think a little bit about that role today. I think it is important to before I really launch into vaccination, to acknowledge the extent to which behavior change did occur, particularly in the early days, and some data from the CDC show us that 48% of people reduced their number of sex partners, 50% reduced one-time sexual encounters, and nearly 50% reported reducing sex with partners on dating apps or at sex on-site venues. So we shouldn't underestimate the importance of this. But if you look at these data, which try and assess the effect of the vaccination versus behavioral change, what you see here between July 2022 and October 2022 across 43 US jurisdictions is that unvaccinated people are in the blue at the top. And you can see that in the black and red, whether people had received one dose or two doses, you can see that there's a significant reduction in incidence per 100,000 people. So you can see that there is an independent effect of the vaccine as opposed to behavioral change alone. So what vaccine are we talking about? Well, we're talking about the MVA variant Nordic modified Vaccinia Ankara vaccine. It's a third generation live replication deficient vaccine, and it's marketed as Jynneos or Imvanex, depending on where you live. And the vaccine course consists of 2 doses, 28 days apart. And the second dose is particularly important, particularly in the context of HIV. And I'll try and show you some data on why. So the World Health Organization has recommended pre and post exposure Mpox vaccination for individuals at high risk of exposure. And the primary preventative vaccination is recommended for people at high risk of exposure to MPXV. And this is men who have sex with men who have multiple sexual partners. And they also suggest that laboratory personnel working with orthopox viridae would actually benefit from it. And they talk about it possible to be considered people with multiple casual sex partners, including sex workers, potentially healthcare workers at risk, and members of the outbreak response team. That's their recommendations. And they do particularly focus on people in the additional groups, in those people who are more likely to have severe disease, for example, children, pregnant women, immunocompromised people. And they talk about primary preventative vaccination is recommended only if there's a high exposure risk. And then they talk about post-exposure preventative vaccination for contacts of cases, ideally within 4 days of the first exposure. But it's really important that the person is pre-diagnosis, when they receive this. In the US, you can see that here are the advisory committee advice. It's very similar. So for people who are gay, bisexual, and other MSM, transgender or non-binary people who've either had a new diagnosis of an STI, more than one sex partner, sex at a commercial sex venue, or in association with a large event, and all people who are have partners of the above or anticipate the above. And they recommend the 2-dose schedule of Jynneos, 28 days between doses. They do comment that modeling suggests that larger outbreaks could occur if the vaccine coverage is less than 50%. And they talk about the vaccine effectiveness as ranging between 66 and 89% for the 2-dose vaccine. And they talk about stable efficacy for people that are immunocompromised. So I think it is important to stop and talk about those people who are immunocompromised. I'm going to focus on people with advanced HIV. So Share led a case series of 382 people living with advanced HIV across 19 countries, and nearly half were immunosuppressed, and 1 in 5 were profoundly immunosuppressed. And half of them were not on effective treatment. And what was found is that the mortality was 15% in those with CD4 count less than 200, and 30% in those with CD4 counts less than 100. That IRIS did occur, and that the authors believe that this meets the criteria for an opportunistic infection. And I think it's really important to remember how severe the disease can actually be, and that it is really, really important that we engage with and try and encourage people who are eligible for vaccination to come forward so that we can prevent this from happening. So I think we have now some more data, and we have some wonderful data from Italian team, Professor Antinori's team from Valentina Mazzotta, looking at immunogenicity and reactogenicity of modified Vaccinia ankara as pre-exposure vaccination against Mpox according to previous smallpox vaccine exposure and HIV infection. And this is a cohort study of anti-MPXV immune responses post-vaccination. And the conclusions that they have come to is that the humoral and cellular response 1 month after completion of the vaccination cycle suggests that MVA-BVN is immunogenic in this situation, that a 2-dose schedule is preferable regardless of previous smallpox vaccination history, particularly in those with HIV, and that it was globally well tolerated despite a higher reactogenicity with the intradermal than the subcutaneous route. And finally, that the intradermal route of MVA-BVN elicited slightly higher titers of MPXV-specific IgG and neutralizing antibodies than the subcutaneous route. At the same time, there were no differences in the cellular responses detected. So it's great that we now have some data, and this is a very recent publication. And you can see that the European AIDS Society has some specific recommendations for adults living with HIV. You can see the usual recommendations that we've seen above, but they have commented that it can be a life-threatening opportunistic infection in those with CD4 counts less than 200. And they've recommended that people with HIV or other causes of immunosuppression who've had recent or anticipate potential Mpox exposure. They talk about, in the case of a vaccine shortage, prioritizing people with advanced disease, and they count that as people with CD4 counts less than 350 or detectable viremia. And they talk about people with advanced HIV or detectable viremia being prioritized also for post-exposure vaccination if available, according to guidelines. So they particularly focus on this group. When talking about vaccination, I think it is really important to think about who is being vaccinated. So I'd like you all in the audience to sit here and think to yourselves, what is wrong with this photograph? And those of you that are thinking they're all males, well, I would disagree, because this is the group of people that have been most affected in the Clade 2B outbreak from 2022. But what is wrong with this photograph is that these are almost exclusively white males. And this happened, in many, many cities. And in the US, what we know about the total US population is that 60% of people are white in the US. However, if we look at those people with race and ethnicity data who were reported as MPXV cases, we can see 30% of the cases were white, so fewer than the actual population. Underrepresented, white people were underrepresented, but they were overrepresented on the right in those people who received the vaccination. So fewer white people got Mpox, yet the majority of the vaccine went to white people. And that is related to, in many cases, how we access people. So at our hospital, we did pop-up events at Black Pride and went out and offered vaccination, in a sort of a low-key way, without making a big song and dance about it at Black Pride. So I think it's all very well having vaccination if no one receives them. And this is just the modeling that I talked to you about populations with some immunity versus population with sort of less immunity, looking at the likelihood of resurgent outbreaks occurring. which could be as large as the previous outbreak if no additional vaccination or sexual behavior adaptations take place. So I think this is really looking at potential probability of an outbreak depending on how many people are vaccinated and how that differs with a population with some immunity. So I think it is important to us to realize that there is the probability of another outbreak, particularly now we know that there is a different strain of the clade 1b virus, which may or may not be circulating to a larger or lesser extent outside of Africa. So what is the vaccine effectiveness? Well, here's a summary on the 2 doses of MVA-BVN as PrEP, so as pre-exposure vaccination. You can see there are a number of case control studies. Then there's some case coverage studies, retrospective cohorts, and surveillance analyses. And what you see here is the study population. And you can see different vaccine effectiveness rates ranging from the lowest at 68% and to the highest at around 90%. And you can see that some of them defined Mpox clinically and some defined it as laboratory confirmed. But all in all, you can see that there is a strong consistent efficacy being reported. Safety surveillance was also conducted during this period when 100 million MVA doses were administered in the US. And the US CDC monitors this vaccine efficacy through the Vaccine Adverse Event Reporting System, through the Vaccine Safety Data Link, and through single patient emergency investigation or new product procedures. And based on this surveillance period, on 66% of first and 34% of second doses, they reported that 90% were male, 51% were administered intradermally, 34% subcutaneously, and 15% by other routes. And it was administered to 1,000 persons. And what could be seen is that these people had a lower risk of hospitalization in the real world. The risk of hospitalization for those vaccinated with MVA-BVN was lower in those people who received a single dose for PrEP, 80% lower with 2 doses, and you can see 58% lower when given as post-exposure prophylaxis. And it's important to say that of those people vaccinated, 41% were living with HIV. So this is helpful information. In terms of the safety surveillance, on the left is the intradermal route, on the right is the subcutaneous route. And you can see that the overall conclusion is that the safety profile was consistent and similar, that SAEs were very rare. There was only 1%, and no SAEs amongst people under the age of 18. But you can see that numerically, the intradermal route seems to have numerically trending towards slightly higher number of adverse events, particularly the skin reactions, which is the site reactions, which we know about. But overall, they were fairly similar. So I'm going to talk about this paper, which from the ShareNet group, which was Mpox in people with past infection or who had received a complete vaccination course, co-led by me and Anaruda Hazra from Chicago. And this is looking at a vaccine infection or post-vaccine infections. And it was a case series early on in 37 men who have sex with men. 7 people had reinfections, 29 were people who had Mpox infections after 2 appropriately spaced BVA-MVN course vaccines. And 1 person had an infection that met the criteria for both reinfection and infection post-vaccination. So those people with natural immunity after the initial infection had a short disease course with less mucosal disease upon reinfection than with their initial infection. And those infections that occurred post-vaccination were characterized by few lesions, little mucosal disease, and minimal analgesia requirements. But 2 people did require oral tecovirimat. And overall, what we can say is that there were no deaths, no bacterial superinfections, and all individuals were managed in the clinic with only 1 hospital admission for antibiotics for a necrotizing neck lesion. I think some further work from Valentina Mazzotta and the Antinori group has also looked subsequently at the kinetics of T-cell responses to MVA peptides up to a year from the Mpox virus infection. And what you can see at T12 is in people on the right, with people living with HIV and living without HIV, is that you do see affected T cells both early and that persist over time at a year. And that there was some retention of functionality, suggesting maintenance of cellular immunity, which is important. Looking at humoral immunity in terms of IgG and neutralizing antibodies in MVA vaccinated versus convalescent people, what you can see is that those people who are convalescent on the right of the panel showed higher antibody titers than those people who were vaccinated. So convalescent serology, the levels were higher. And also that there were lower levels of antibodies, both IgG and neutralizing antibodies in the vaccinated individuals without a history of smallpox vaccination during childhood. So those people that were called MVA naive, those are the people without a smallpox vaccination in the past. So we now know some information a year on around both T-cell immunity and neutralizing antibodies in people who've had a smallpox vaccine and in those people who are convalescent. So this is a real helpful paper in terms of moving the field on. So that I've pretty much summed that up. And that vaccinated people showed longer term specific humoral responses, but higher T-cell responses in convalescent people. And that HIV infection didn't influence the long-term humoral and cellular responses. And these are very important findings in terms of need for boosters. Finally, there's some things I'd like you not to forget. I think it's quite obvious that Mpox has not gone away. In fact, we've developed a new clade in the world due to the fact that the next slide, which is that no one is safe until we're all safe. And we're clearly not all safe because up to this point, we do not have the vaccine that is needed in the DRC and other countries that are affected by the clade 2B outbreak. I mean, clade 1B outbreak. Indeed, anybody who's dealing with clade 1 or in fact clade 2, we're missing vaccine in Africa in general and in many other LMIC countries. And we can see that without this, we cannot contain these outbreaks unless they're contained at source. So it's essential that this happens, and it's a travesty that it hasn't happened and that we may take this to make it happen. Which is why activism remains really important. And I think that we all have the capacity to speak up and use our voices to do what we can to try and leverage change. And the change that we really need now is vaccine in the places that need it, which is not, in my view, for people who are traveling to Africa or affected countries in Africa, but it is for people that are in Africa and experiencing this disease. So thank you for your attention. And I'd also like to thank everyone who's collaborated with me as part of the ShareNet collaboration on Mpox, most particularly the patients who've allowed us to report the data.